To start with the next session, I call Dr. Professor Ruchi Goel to please switch on the camera and unmute herself. Over to you, Dr. Ruchi.
Thank you. Thank you so much. And I'm already there. Just to confirm, my co-speakers and co-instructors, Dr. Raj Anand, Dr. Shalu.
Hi, Dr. Ruchi.
Yeah, and, Dr. Samreen. I hope all of you are there.
Yes, ma'am.
Yeah, so I would request the previous participants to please put yourself on mute so that we can start with the proceedings right away. So a very good morning to all our listeners and welcome to the panelists. This session, as you can understand, we are going to discuss the sequelae of the trauma. Once the trauma is there, already, so many things are happening to the patient. And over a period of time, the things remain, the trauma, the after effects of this trauma remain, and the patient and the relatives and the doctor, they struggle to bring back the functional and the cosmetic dysfunction that has been brought about. So we would like to start right away. Dr. Samreen is a senior resident at our center, that is Maulana Azad Medical College. And in our residency, they encounter so many patients with trauma. They do the primary repairs, and she will be discussing how to manage the orbital foreign body and when to intervene. She is a very enthusiastic oculoplastic surgeon, and she will be sharing some of the cases which we have already published. And over to Dr. Samreen, please.
Thank you, ma'am. Good morning, everyone. Today I'll be speaking on cases of orbital foreign body and when to intervene. Just a minute.
May I please request the other participants either to leave the forum or please put yourself on mute.
So approximately 16% of cases of orbital trauma that are encountered in clinical practice are associated with the foreign body. And many of these cases may have rather unusual presentations. Some of these cases of orbital foreign body may accompany trivial trauma, especially in children. The history might be ambiguous, and the diagnosis and management of intraorbital foreign bodies often proves to be a conundrum for most ophthalmologists. So I'll be just sharing some cases with you. This is a 4-year-old male child who came to us with features of right-sided periocular edema, orbital inflammation, impaired motility, a relative afferent pupillary defect, and a pale optic disc. Clinically, the picture was that of an orbital cellulitis. Purulent discharge was also present over there, and which was on microbiological examination, it was found to be Staph aureus. The patient was started on intravenous antibiotics. There was resolution of edema, improvement of motility, but there was persistence of a discharging sinus on the superomedial part of the orbit. So we reviewed the scans, and then we realized that there was a relatively radiolucent linear object running along the medial wall of the right orbit from anterior to posterior. Upon further questioning the parents did give a history of injury to the right eye while playing 5 months back. So we planned to do a surgical exploration. Now, intraoperatively, we found that it was a plastic foreign body about 3 inches long and half an inch wide, and was identified as the rear side of a plastic ballpoint pen. After the removal of the foreign body, the discharging sinus resolved, and the symptoms were totally gone, although the vision was still less because of the optic atrophy that had occurred as a result of the trauma in this child. There's another child who was a 10-year-old male who presented with history of trauma with a ball pen while playing, and there was sudden diminution of vision in the right eye along with drooping of the eyelid. On examination, there was no light perception in the eye. There was an entry wound below the lower eyelid with limited ocular motility in all the gazes, a relative afferent pupillary defect, disc papular, and a hypoesthesia along the right cheek. Initial non-contrast CT was inconclusive. A repeat CT and MRI were done, and a linear non-metallic foreign body could be seen extending all the way up to the apex. So it was diagnosed to be a case of right traumatic orbital apex syndrome, and surgical intervention was recommended. You can see the scans here. The foreign body, a relatively radiolucent foreign body, which was missed on the initial CT, going all the way up to the apex, and here on an MRI also, and it was also impinging on the optic nerve. Now this child, the poor prognosis was also explained while advising surgery to this patient because of the disc findings and the pupillary RAPT, and they refused surgical intervention, but he was given steroids and the movements did improve following a course of oral steroids. Now, this is another case of a 36-year-old female with a history of recurrent swelling of the left lower eyelid. There was purulent discharge from a pus point near the medial canthus, but the syringing was patent. And on USG and NCCT, we could not find any abnormality. So an incision was given near the area of pus discharge, and a wooden fragment was isolated, which was about 1 inch long. Thereafter, the patient said that she had some history of trauma while cutting wood about 8 months back. This is another case, a 30-year-old male who came to us with a history of injury with a BB pellet can. In fact, he had BB injury sites all over the body, and he was referred to us for evaluation. So he did not have any ophthalmic symptoms or any complaints as such, but we did see an entry wound at the left glabellar region. On NCCT, a metallic foreign body was identified adjacent to the medial rectus muscle, and surgical intervention was undertaken. Now, this foreign body was a BB pellet, but during the surgery, there was posterior migration of the BB pellet, as the patient was rather asymptomatic and BB pellet is an inert object. We did not seek any further intervention going into the posterior part of the orbit. So one can see that in many cases of orbital foreign body, there might not be any definite history of trauma at the time of presentation, or there may be history of relatively trivial trauma in which many of us might not suspect a foreign body. And this becomes very difficult in case of children who are not able to give a history, and sometimes the history is very ambiguous. So we should also know that foreign bodies in the orbit can have a very diverse spectrum of clinical presentation, such as orbital cellulitis or an orbital abscess, an orbital hematoma, a persistent discharging sinus, or in the form of an orbital apex syndrome, a supraorbital fissure syndrome, and injury to the optic nerve can result in optic atrophy. So as far as the imaging is concerned, plain X-ray is useful in identifying metallic foreign bodies, but aluminium might be missed. B-scan ultrasonography requires, it is an observer-dependent technique, and while foreign bodies might be identified in experienced hands, it might be difficult, especially in many cases where there is a lot of inflammation and fibroadipose tissue growth. On computed tomography, and also B-scan is not useful for posterior orbit and anything that is located near the apex. As far as computed tomography is concerned, it is considered to be investigation of choice for a suspected intraorbital foreign body, and enables us an accurate localization of high density foreign bodies, especially metal and glass. And it is said that it has been seen that about 0.3 mm size up to 0.3 mm size of metal foreign body and 0.5 mm size of glass foreign body can be identified. Now, another very challenging thing is wood, as we saw in our cases too, which is a relatively low density object and becomes very difficult to identify it on a computed tomography. It is because, and that wood density also differs on the nature of that wood. Like dry wood is hypodense and it mimics air, and fresh wood is isodense and may mimic fat. Now, plastic foreign body in one of our cases was also not identified on initial scans, and it was again identified later on only because of its variable radiolucency and is seen to often evade detection on imaging. Magnetic resonance imaging should be sought only after one has ruled out a metallic foreign body. And it does enable a better assessment of soft tissue damage, especially when we are trying to see the extent of damage at the orbital apex. Wood is seen to be more relatively more easily identified on MRI and is hyperintense relative to fat and is more discernible on a T1 weighted imaging. So basically, any case of suspected orbital foreign body, anti-tetanus prophylaxis and antibiotics should be given, and the decision to remove should be weighed against the risk of iatrogenic damage. Organic foreign bodies are often associated with infection and intense inflammation, and it is advisable that they should be removed. Copper also, even though it is a metal, it also leads to intense inflammatory reaction. Iron can be inert, but it can also lead to siderosis over a period of time, the release of iron from the foreign body. And if it is not removed at the initial time presentation, then one should do a routine ERG to assess for any early signs of siderosis. And at that point of time, it is mandatory to remove it. BB pellet, as we saw in one of our patients, is generally well tolerated over a prolonged period of time. But yes, definite any metallic foreign body, even if it is inert, removal of that actually removes the contraindication for a magnetic resonance imaging. For foreign bodies that are located at the orbital apex, a transcranial and a transnasal or transethmoidal approach may be adopted with collaboration with neurosurgeons and ENT surgeons. These days, a number of image guided systems have been developed that acquire a precise local, that give us a rather precision in terms of isolating the foreign body intraoperatively and causing minimal collateral damage to these structures. And we advise a tailored approach, as each and every case might be different, and the choice to intervene and the approach of intervention might differ in each and every case. We published our findings and the number of cases that we had seen in this paper, which was published later last year. So to sum up, in any case of suspected orbital foreign body, we are supposed to do a thorough assessment, and NCCT of the orbit is considered to be the initial imaging modality of choice. When it is inconclusive, or if there is definite evidence of organic foreign body and a metal foreign body has been ruled out, one may go for a magnetic resonance imaging. Before that, you're supposed to start broad spectrum antibiotics, anti-tetanus prophylaxis. In case of a foreign body that is organic in nature, surgical removal should be done. For inorganic foreign bodies, if there is persistent inflammation and it is amenable to easy surgical removal with optic nerve compression, if optic nerve compression is there, then surgical removal should be preferred. For foreign bodies that are very inert, posteriorly located, and the risk of iatrogenic damage is more than the risk of retention, one may opt for a conservative management. Now, it is important to note that organic foreign body, especially wood, we should do a post-operative check MRI, because many times splinters and small residual fragments are retained even after removal. And yes, for iron foreign body, definite surgery. If it is not done, then it is important to follow up these patients, as we had discussed previously. Thank you.
Thank you, Dr. Samreen. It was a very comprehensive talk that you gave, and I'm sure your experience over the time, it must have taught you that any patient with orbital cellulitis, especially in children, where you cannot find a reason why it is happening, one really needs to ask leading questions as to the history of trauma. And all these patients, I think many of the panelists must have experienced that simply an ultrasound or simply an X-ray, plain X-ray may miss the foreign body. So a very you have to be really looking for it to find it. And the image which you showed of that patient who had actually been referred to me for acute dacryocystitis. And eventually over the time, and when we kept on asking what really happened, then we got to know that she had exploration had already been done twice. So a very half-hearted explanation may not at times help, and you have to go in deeper, and wooden foreign body over the time, it's almost like it gets mixed up with the soil, it gets mixed up with the orbital tissues. So it's, and the moment you remove these foreign bodies, immediately all the symptoms relieve. So any you would like to add anything else? Anybody else would like to add anything else? Dr. Shalu, Dr. Raj, anybody? Samreen, Smriti, anybody would like to add their experience?
Yeah, Dr. Ruchi, this has been already emphasized that we should keep high index of suspicion in cases where we don't find the cause of the symptoms. And sometimes we don't see anything, but the patients keep on complaining that I have a pain near the supraorbital or eyebrow. So we should listen to the patient, and patients are always right, and we should explore these cases.
Yes, in fact, this is a very good message that you have shared, Shalu, that when the patient complains, we should not think he's complaining. They're actually right, and we need to look into it more carefully. Thanks so much. And I think we'll go to the next talk now. So I think first we will finish with the lacrimal surgery talk. Dr. Malik is not there with us because of some personal reasons. So I think I'll take the last talk which was there, and then we will see if there is time, we'll take the glaucoma talk also. So so many times post road traffic accidents or any other assaults, so many times after all the initial repairs have been done, the patient will come back to you with little cosmetic blemish and continuous watering. Now at this stage, we really need to know why this watering is occurring. And just to recapitulate the anatomy of the lacrimal excretory system, we can see that when we talk of the anatomical classification of canalicular blockage, it is the first 3 millimeter is the proximal blockage, the next 4 to 6 millimeter is the mid-level blockage, and the distal would be something beyond 6 millimeter from the punctum. So the medial canthal ligament, the upper tarsus and the lower tarsus, the join, and the medial canthal ligament, it goes and attaches to the anterior lacrimal crest and the posterior lacrimal crest. So this is the area where when the trauma occurs, mostly the medial canthal ligament would also be traumatized. So just to go through this video. Now, this is a case with post-traumatic telecanthus with there was a granuloma formation and there was a canalicular damage. So the first thing one needs to ascertain is as to what is the extent at where the blockage is occurring. And you need to dissect very carefully so as not to traumatize the tissues that are there. And the probes have to be kept in situ while this dissection is going on, so as to prevent any accidental damage to the canaliculus. So once that area is identified, suppose all is lost, then you need to really work around the anterior lacrimal crest to identify where the sac tissue would be there. Sometimes even the sac is damaged. So whatever you have, maybe you need to create the flaps from it. And this is a long nasal mucosal flap that has been created to because the lacrimal sac was already damaged. Now this is the how you repair the telecanthus, and what you do is you take a bite very close to the medial angle, and this is a 6-O-proline being sutured, and you take the other bite very close to the periosteum and as posterior as possible. So if you don't take it posteriorly, you tend to have a distorted medial canthal and your punctum may end up everting. So this is a very important aspect when when you're repairing a telecanthus. Now, management, see, if you have a distal canalicular block, then the management is not that difficult because most of the time you would get away with a canalicular DCR. Whereas when you have a proximal or mid canalicular block, then one needs to be very careful because the DCR giving a very reproducible results. The management of proximal and mid canalicular blocks are sometimes very tricky. So initially one should go for a canalicular trephination, and if possible with trephination we can attempt an intubation. If this does not work out, then of course a lot of other techniques have been described, but what I like to do is a retrograde intubation with dacrocystorhinostomy. This technique has been studied quite widely now, and initial reports showed good results in proximal canalicular obstruction. So what you really require for this is the lacrimal probe, which has been bent at 80 degree. And just to share a video. So this is a usual skin incision for the DCR that we give. Now we have to be careful when we are opening the lacrimal sac area. So the lacrimal sac area is very carefully opened, and a vertical incision should be done. The common canalicular opening is identified, and then after this, the probe, which has been bent at 80 degree, it is passed from within the common canaliculus towards the conjunctival side, and wherever you experience a soft stop, you can give a nick on the conjunctival side to create a pseudopunctum. So you do repeat this on the lower side of lower canaliculus also, and after that the intubation is done. Now the problem with intubation again is sometimes the stent gets detached from the silicone probe tube, and so what I have started doing is, first I pass an adult stent, and after there is a kind of a dilatation of the passage, then I passed a pediatric intubation set, and this is the usual way that the intubation is done, and the wound is closed in layers. One additional thing I started doing is I suture the edges of the pseudopunctum with a 6-0 vicryl suture. So this was not described in the initial reports. Now this is how it appears. So this is the natural punctum in this patient, and you can see this is the pseudopunctum. So it is, of course, the pseudopunctum is located a little medial to the true punctum, but it functionally it works. And this is the anterior segment OCT picture of the pseudopunctum. We have already published the OCT findings of these pseudopuncta and how they appear. And hopefully it will be published soon in one of the journals, the series. We have had good results with this procedure, provided you choose the patients properly. And I'll just at the end summarize which patients did well with this kind of a technique. Now, this is, of course, when you have a proximal block, this is the external conjunctival DCR, which is a gold standard. And here again, osteotomy is created. Now, creation of flaps is again, I have done patients without creating these flaps and just sacrificing, and they do well. So it is, it's basically that your tube has to be placed well. And this, I don't excise the caruncle, I just partially snip it off so that space is created. And then if you don't have a von Graffi's, you can even use the this MVR blade to create the passage. And this goes right into the, from the conjunctival side into the pre-dissected passage. It goes into the nasal cavity. And the length, as I've already told, that you take a probe and just 2 millimeters short of what it touches the septum, nasal septum has to be taken. Now, this is the tube which has been fixed with the mirror tuck technique, the details of which, of course, you can read from the article in IGO. And it has been a very been giving very consistent results, and now it has become a very at least I use it in every patient. And this is just a straight glass tube which has been used, which is just 500 rupees, and it fixes well and it stays well. The only thing is that on table you must be sure this is a 6-0 proline suture which is being used to fix the tube, and you should ensure that your tube placement is correct. So this is suturing of the lacrimal sac flaps and the nasal mucosa. But as I said, even if you don't suture them and just sacrifice, it works. So this is on table. You must check that your, the fluid is draining properly, because if on table it doesn't drain, it is unlikely to function at a later stage also. So this is very important. So to conclude, if you have a patient with proximal block, initial intervention should be trephination with intubation. If it doesn't work, then you can go ahead and do a DCR with retrograde intubation, provided that there is not an extensive trauma to the tissues with a lot of fibrosis. Sometimes we have had patients with road traffic accidents where there are foreign bodies within and there are a lot of fibrosis. So in those cases where already there is so much fibrosis, this we found that this it becomes very difficult to actually intubate the remaining canaliculus. So there I would directly go for a conjunctival DCR with the bypass tube. Any patient which does not over the time there is a failure following DCR with retrograde intubation, again in those patients also I would like to do a CDCR. For distal blocks, I would go for a canalicular DCR with intubation. And any patient where you have a telecanthus should be repaired simultaneously using a Prolene suture. So that is it from my end. Any questions I would be very happy to answer. Yeah, anyone wants to discuss? And Shalu, I think you have quite a, yeah.
I would like to know the source of your glass tube.
It is the glass tube source. Actually, this is the same tube which you had actually instructed that person to make at the same time. And on my request, because possibly we have more cases of trauma coming from UPR, so we told him to arrange it, and it is available outside our hospital. So, yeah.
And any experience, you prefer Botox injection for Epifora, or you prefer do the conjunctival DCR?
I knew you were going to ask this because of late, I think Botox has become we have been giving Botox. I would not say that we have not been giving Botox, but Botox, the expense and the recurrence that at least, you have to give it twice or thrice, that you agree. Not in one injection, the Epifora is not going to go away completely in most of the patients. So yes, I have given Botox in the lacrimal gland for some patients, but yes, routinely I don't, because most of the Botox, one thing, the supply that is coming is not for this purpose. It is meant for, nephrospasm and all those kind of things. So we have to use it very judiciously. So, but yes, I agree with you. Botox has been giving good results in all these functional Epiphoras. I agree with you totally. Yes. So what is your experience? What do you do about it? Let's
my conjunctival DCR has reduced a lot because we need to follow up them very often, and they are outstation patient, and to get them to OT because they have granulation tissue and this. So in my practice, I prefer Botox rather than conjunctival DCR.
Yeah. Okay. Dr. Raj is not there. Dr. Raj Anand has joined. I can't see him also.
Yeah, I don't think so.
Okay. Smriti, you want to share your experience?
Ma'am, actually, I just wanted to say thank you for sharing such a wonderful video of retrograde intubation. It was something new that, we also learned. So beautiful video there. So just wanted to say thank you for sharing that.
So I think we can go to the next talk after this. So the next talk is, I think Dr. Raj's talk was there, or maybe we can take some other one if he is not there. So I think it's Dr. Shalu, we can take your talk. It's lid margin and abnormalities by Dr. Shalu Bageja. She is a senior consultant at Gangaram Hospital, and she has been doing she's a totally dedicated oculoplastic surgeon, a very quiet and a very skilled oculoplastic surgeon. I must describe in 2-3 words. So over to you, Dr. Shalu.
Can you see my screen? Thanks, Dr. Ruchi, for your kind words and including me in this session. Eyelids, we all know. Can you hear me? Am I audible?
Yes, ma'am. Yes.
Yes, doctor.
Okay. Eyelid is a very important structure, and we all know it protects our globe and is vital for maintaining the integrity of the ocular surface. These traumatic deformities can be due to the delayed, inadequate, or improper primary repair, and they may have disastrous visual consequences. So one should have a clear understanding of the anatomy and physiology and the surface landmarks before planning for the reconstructive surgery. And whenever the patient presents with a traumatic deformity, detailed history should be noted regarding the circumstances of injury, the primary repair details should be documented, all the symptoms should be recorded, and it's better if we can have a pre-injury photograph so that we can have the facial anatomy and the landmarks available to us. Detailed ophthalmic evaluation is must, as they may be associated trauma like fractures or lacrimal system. So detailed ophthalmic evaluation is must in all these cases. So I'll be basically discussing some of the deformities which we commonly see, like marginal misalignment, traumatic epicanthal fold, canthal displacement. Telecanthus has already been described by Dr. Ruchi, doses, eyelid defects, cicatricial entropion and ectropion. So marginal repair is key for all eyelid repairs, and I'll be just sharing a small video showing the basic principle of marginal repair. And if the primary repair is done meticulously, then we may avoid these deformities. In this case, we are in marginal repair, we have to take 3 millimeter from the cut end and come out from the depth, same depth, and come and go to the other cut end at the same depth and from 3 millimeter from the cut margin, and go back at 1 millimeter from the cut end, coming out from the same depth and coming back to the other cut end. The suture is tightened such that there is slight outpouching, and so that when it heals, it flattens and we avoid the notches. So the first incision suture is passed through the grain line, second is at the posterior margin, and the third one is at the anterior lash margin. The sutures are tightened and brought forward so that don't irritate the ocular surface. The suturing can be done with a 6-0 nylon or 6-0 silk suture. This is a patient who presented with 4 days after repair, and he had a cicatricial ectropion, and so the wound was freshened up and resuturing was done so that we could achieve the good opposition. Epicanthal fold, if present, obscures the medial angle, and it is due to the vertical deficiency of the tissue rather than the horizontal plane. So Mastardi has described this technique for repair of epicanthal fold. Since then, various modifications have occurred, and we should opt that which shows the best result in our hand. This is a clinical example of a patient with a double Z plasty was done. And after giving the incision, the skin and the subcutaneous, there is a relocation of the flap so that we can lengthen the vertical plane. We can also go for Y to V plasty. So we should choose the procedure. There are many modifications like CU and other modification, which gives best result. You can opt for the method to treat this epicanthal folds. So whenever we present the patient present with trauma, it is important that we should do the canthal examination, because any loss of the contour and angulation, we should be repaired. Otherwise, we have these canthal dystopia, which lead to the facial deformities and epiphora. Medial canthal deformity is more important because the complex structure is there. And these can be soft tissue deformities or associated with naso-orbital ethmoidal fractures. And we can require a variety of different techniques to tackle the deformities. So one should be well versed with the anatomy of the medial canthal tendon, and the posterior lacrimal crest attachment is the mainstay of the treatment. So whenever we are repairing any medial canthal injury, we should repair the posterior crest and attach the whatever remnant of medial canthal tissue is available to us at the level of the posterior lacrimal crest. So we should go as deep as possible with the Prolene double arm suture. If we don't have a periosteum, then we have to go for mini plating, or if there's loss of bone and everything, we can go for transnasal wiring also. This is a clinical picture of patient with the medial canthal deformity, and the transcaruncular approach was used, and with the 4-Prolene suture, the canthal tendon was attached at the level of the posterior lacrimal crest, and this shows a good tightening of the tissue. The telecanthus can be repaired using both the transcutaneous and the transcaruncular approach. And in this, both the approaches were used, transcaruncular as well as the transcutaneous. And the Y to V approach was used in transcutaneous approach. And the medial canthal tendon was tightened, and we could achieve the good depth. This is another example of patient who had a scalp and forehead scar, which is pulling the medial canthal tendon above, and we can see the eyebrow being pulled upward. So here the whole flap was raised, the scar was revised, and the canthal tendon was sutured at the level of the posterior lacrimal crest, so that we achieved the good eyebrow positioning as well as the good depth of the medial canthal tendon. So the crux is that we should go attach the medial canthal tendon or whatever tissue is available deep to around the posterior lacrimal crest. In case of lateral canthal dystopia, we should be aware that we should, whenever repairing, we should know that the lateral canthal tendon is slightly higher than the medial canthal tendon angle, and we should be anchored at the level of the Whitnall's tubercle. So it is important that the avulsed tendon should be sutured at the level of the Whitnall's tubercle. We should pass the suture. We usually use 4-0 proline suture, pass from the periorbita and come out at the periosteum, and slightly higher at the higher level from the medial canthal tendon. And we should slightly overcorrect them because there is some regression. This is another example showing the web and ectropion. Here the patient was managed with Z-plasty with lateral canthoplasty. Coming to traumatic ptosis, these can be due to myogenic if the patient has not been sutured, levator suture has not been done in the primary repair. So whenever there is a fat prolapse, you should suspect there is a levator injury. If repaired properly, then we may prevent the sequelae. It could be aponeurotic, neurogenic, or mechanical, or cicatrization, or there may be a combination of factors. So detailed evaluation is must whenever looking for going for a ptosis repair. Importantly is looking for Bell's phenomena, motility, corneal sensation, and phenylephrine if it's a milder form of ptosis. The timing, we should wait at least for 6 months because sometimes there is a spontaneous resolution in neurogenic cases, as well in patients with edema. But however, we need to counsel them that may require multiple sittings. So depending on the evaluation and levator function, we can choose any of the procedures. So this is an example of a traumatic ptosis who had undergone a levator surgery and showed good result. However, we do find some difficulties like tissue identification and manipulation may be difficult due to excessive fibrosis. And we may encounter excessive bleeding, and sometimes more sutures are needed to create the late fold. But in best of the situations, we may not get the best of our fold, and the patient had good correction, but the lid fold was not good enough, and they may have lid lag and lag of ophthalmos. We should explain them prior to surgery. These are the side effects of the going with the surgery only. So if there is a ptosis is severe, we have to go for stylistic sling. In case of traumatic colomas or eyelid defects, we need to have follow the basic principle of reconstruction, and depending on the extent, we can combine the various procedures available to us. This is a patient who had a traumatic lower lid ectropion with retraction and was managed with pentagon excision with marginal repair. The pre and the post-op picture showing the relief of retraction. So another patient with eyelid notch, and here the pentagon excision was done, and because of the laxity, we could do the canthotomy and cantholysis, and the direct repair was possible. If the patient presents with this coloma, then we have to repair both the posterior lamella as well as the anterior lamella. Here we could do the tarsal rotational flap, and the anterior lamella was repaired with the post-auricular skin graft, and this is the outcome after the repair. Coming to entropion is basically due to the shrinkage of posterior lamella, and they may be associated with trichiasis or dystrichiasis, especially after Steven Johnson or chemical injuries. So we need to see the severity of the disease and the state of our tarsus whenever we are planning for surgery. So when we are planning, we have to give them a lot of lubricants, and we can bandage contact lens so that we can protect the ocular surface. Trichiasis we can manage with radiofrequency ablation, and in case of dystrichiasis, if it is localized, we can do radiofrequency ablation. But in a sectoral cases, we have to go for eyelid splitting with cryotherapy. And in generalized, we have to replace with them with buccal mucosa. This is a patient who had a sectoral dystrichiatic lashes. So eyelid splitting was done and double freeze thaw cycle was done to treat the dystrichiatic lashes, and then the suturing was done. Generalized involvement, we have to go for posterior lamella.
You can go on. It's okay. We have time. Please go on.
Thank you. So we can do the posterior lamellar resection is very important, and it has to be meticulous because we have to remove the root of lashes so that they will prevent the recurrence. And then we can replace it with a mucous membrane graft. There is a lip mucosa is taken and sutured. Sometimes we can use the glue also. It's a 1 month post-op of the same patient. In case of entropion correction, we can use the tarsal rotation procedure, blepharotomy, or in severe cases, we have to go for posterior lamellar shortening. In tarsal rotation procedures, we have wedge resection or tarsal fracture. In mild to moderate cases, if we have thick tarsals, we can go through the skin approach. We can remove the wedge of the tarsus and do the wedge resection, which helps in rotation of the lid margin. So this is a small video. Can I go with this video?
Yeah, please.
The tarsal fracture in severe cases with thin tarsals, we can go do the tarsal fracture rotation. And after doing the hemostasis, we mark at the we leave the 4 millimeter from the eyelid margin and do the marking. And do the radio frequency, use the radio frequency to go through the full thickness of the tarsus. And after doing the undermining, we can use a double arm 5/0 nylon sutures to pass through the distal end and then come out from the, this is the 450 nylon being passed, and then we come out through the below the this posterior lamella from the near the lash line, so that we can achieve the good rotation, and this suture is passed through the bolster. So we use 3 double arm sutures to have the full length of the eyelid being rotated. So this is being passed through this, and we aim for slight overcorrection in these cases. So this is another suture being passed. So 3 sutures, and we just check the rotation, and then we tighten the sutures accordingly. So in case of posterior lamellar shortening, we take the post mucosal graft or chondromucosal graft. This is the patient. In this, the subtarsal dissection was done. We removed this thing, tarsal, lower lid retractors and conjunctiva, and put the hard palate graft in between so that we can lengthen the posterior lamella, or we can use the mucosal graft. Lid ectropion in trauma cases occur due to lid laxity or circuitry shortening of anterior lamella, or orbicularis muscle weakness, or paralytic causes like facial palsy. So basic principle is lengthening of the cutaneous surface and resection of cicatrician and horizontal lid shortening. We have to assess the laxity in all these cases, and laxity can be tackled by the lateral tarsal strip, which is the versatile technique, can be managed in all cases like entropion or ectropion. We have to create a tarsal strip by removing the anterior epithelial as well as the conjunctival surface, and we can tuck it at the level of the Wittnar's tubercle. This is a small video, I'll just skip it. And then in case of cicatricial ectropion, we have to assess whether it's a localized or generalized. In localized cases, we can do a Z-plasty or VY-plasty. So it is basically Z-plasty is done to lengthen at the line of the scar. The clinical example of a localized ectropion showing making a V, and after doing the undermining and removing all the cicatrized tissue, we close it as a Y so that we can pull back the lid upwards. In case of generalized, we have to take the graft. It can most use this symmetrical is upper lid, but we can use the retroauricular graft also, and it should be about 25 to 30% extra. So video I'll also skip. This is just showing the pre and the post-op after post retroauricular graft. That's the improvement in the ectropion. So prevention of eyelid deformities can be done if we do an early meticulous primary repair, and anatomical restoration is must. And traumatic eyelid deformities can be corrected with satisfactory cosmetic and functional results, but we have to explain to the patient that they may require multiple sittings. Thank you.
Thank you, Dr. Shalu, for a very comprehensive and I think we will take the discussion later, because let's finish the talks first. And you've already touched upon the traumatic ptosis. And now Dr. Smriti Nagpal would speak in detail how to really assess a patient with traumatic ptosis and what all modalities we have available. Dr. Smriti, please.
Thank you, ma'am. Shalu ma'am has already introduced the topic, so I'll just take it further from there. Okay, coming to traumatic ptosis, am I audible?
Yeah.
Traumatic ptosis is a subtype of acquired ptosis. It's the second most common type, the most common being the aponeurotic ptosis, which is seen due to stretching, disinsertion, and dehiscence of the LPS aponeurosis, most commonly in the elderly. Other causes of acquired ptosis are myogenic ptosis, neurogenic, and mechanical ptosis. Determining the cause of an acquired ptosis is critical to the choice of therapy. One must rule out a serious underlying neurological disease, and a careful evaluation of the pupil, the ocular motility, and facial sensation is a must in all cases. Pseudotosis has to be ruled out. Traumatic ptosis can be from a broad range of insults, varying from direct muscle injury to bony injuries, mechanical effect from scars, cranial nerve damage, and effect of neurotoxins, especially Botox. Depending on the mechanism of injury and the physical findings, we can divide it into myogenic, aponeurotic, mechanical, neurogenic causes, ptosis types, and they can be a mixed mechanism. Myogenic is due to direct injury to the LPS molars complex, as is commonly seen in lid lacerations, like ma'am showed, and also in cases of direct injury like a knife, trauma with a knife or a sharp object. In this case, ptosis is generally severe with impaired LPS action, and here we need immediate surgical intervention with repair. Aponeurotic ptosis can occur due to dehiscence, disinsertion of the aponeurosis. Here, this may be due to a large hematoma or ecchymosis or edema, postoperative edema, severe edema. Birth trauma, iatrogenic causes are normally result in aponeurotic ptosis, and such patients normally respond well to surgery. Mechanical ptosis is because of cicatricial bands, which can cause a tethering and stiffening effect. Traumatic neurogenic ptosis is because of injury to the cranial nerve or to the sympathetic fibers, like neck injuries can lead to post-traumatic Werner syndrome, which can cause a mild ptosis. A lot of patients can have more than one subtype. Like in this case, we can see the direct injury to the LPS. This patient was a case of a road traffic accident, so he had a bony injury. And we also see this scar, which is leading to the tethering of the upper lid skin and causing severe ptosis. Iatrogenic traumatic ptosis is commonly seen post-cataract or glaucoma surgery, where a brittle suture is used. It can be seen post-squint surgeries, especially superior rectus. It can be seen due to trauma during blepharoplasty. Post-op scarring, edema, or hematoma can lead to a ptosis, and Botox leads to temporary ptosis at times. Ptosis with facial trauma can be seen with orbital root fractures, wherein the pieces of bone can directly abut the muscle and damage it, or fractures which can lead to supraorbital fissure syndrome involving the cranial nerves and causing ptosis. Facial trauma fractures can lead to enophthalmos and pseudotosis, which should be ruled out. And this is a case of a fracture wherein we can see the scar, which is the entry wound, and patient has enophthalmos, patient has mild ptosis, and patient has limitation of motility. We can see that the eye, there is deficient adduction and there is deficiency in down gaze. Neurogenic traumatic ptosis occurs with the cranial third nerve palsy, which is common after blunt trauma to the head, closed head injuries, road traffic accidents. Here, generally, we see a complete ptosis, and which often resolves spontaneously without any treatment. However, aberrant regeneration and synkinesis may occur. Coming to the evaluation of a patient, history is very important. The mechanism of injury, history of any prior surgery, the onset, duration, and variability of ptosis, whether any improvement has occurred over time, whether the ptosis is unilateral or bilateral, if the patient has any abnormal movements or recent onset squint or diplopia. And of course, prior to planning any surgery, we should take a proper history of any systemic illness and associated conditions. Evaluation in case of trauma. Firstly, in case of polytrauma, road traffic accidents, one must assess the general wellness of the patient. Airway, breathing, circulation, and disability scoring is most important. Once that is established, and then we move on to the ophthalmic examination. We look for any entry wound or scar tissue. We look for associated eyelid, orbital, intraocular injuries. We must rule out a globe rupture. We see associated telecancers, associated epiphora. We look for any eyelid edema, ecchymosis, abnormality in muscle movements. Check the pupillary actions. Check for any aberrant movements, any enophthalmos, any scarring. So all this is significant in case of trauma. Along with that, a complete ptosis assessment is important, wherein we see palpebral aperture, we check the LPS action, the bells, the lid crease, the corneal sensations, and the lid lag. The lag of thalamus. This is another patient who had, we can see this scarring wherein the trauma occurred. This patient had severe ptosis, and along with that, the patient had a third nerve involvement. So I'll just play the video. We assess the movements. We see this deficiency in down gaze. There's deficiency in up gaze of the eye. Then we see that the abduction is occurring, but the adduction is deficient. And then we see that the patient has a fair bells. After the clinical evaluation, we assess whether any special tests are needed, like a phenylephrine test, especially in case of corners, and any imaging, orbital intracranial imaging if required. Management of traumatic ptosis can be conservative or surgical. Like Shalu ma'am said that often we like to wait for 3 to 6 months before rushing to management. So conservative management is important in case there is any spontaneous improvement which is expected, or in cases where there is severe, where there's poor bells and there's risk of exposure keratitis post-surgery. So obviously in those cases, we don't go for surgical repair. Spontaneous improvement is commonly seen in mechanical cases, in mechanical subtype where there is edema, hematoma, which will normally resolve with time and ptosis improves. Post-operative ptosis also shows some improvement with time. So we wait for that to improve, the inflammation to settle, and then we see if any repair is needed. Neurogenic ptosis, we typically wait for 3 to 6 months for improvement to occur. So we intervene if there is either no improvement or the improvement has plateaued out and no further improvement is occurring. In determining the optimal surgical approach, one must consider the etiology of ptosis, the LPS action, the severity of ptosis, the associated nerve palsies, and the Bell's phenomena. Upper eyelid lacerations notably need immediate repair. In this case, like ma'am rightly said, if there's fat prolapse, then we know that the septum has been violated. So we suspect that there's injury to the muscle and the aponeurosis. In such cases, delayed repair is generally more difficult because there's scarring of the tissue and identification of muscle becomes difficult. For such patients, we normally, how we proceed is we identify the orbicularis fibers, then we release the septum, we identify the fat, and normally the aponeurosis muscle is lying behind the fat. Often because of edema and severe hematomas, identification is difficult. So in such cases, we can grasp a suspected tissue with our forceps and ask the patient to look up. If we feel a tug on it, we know that we have caught the LPS muscle. Cases associated with orbital fractures may need delayed repair because in these cases, primary importance is given to the fracture and the associated nerve injuries. And after that, we come to the ptosis repair. Mechanical cases, we avoid aggressive surgeries because in such cases, risk of lag of thalamus, post-op lag of thalamus is pretty high. Surgical options vary from a simple fascicular servot, which is done in mild cases, especially in Horner's, to LPS resection plus minus advancement, aponeurosis repair. Frontalis sting is done in cases of poor LPS action, and additional repair and additional scar release may be needed in some patients. This is a short video showing sling surgery, which I think we can skip. Satisfactory resolution is generally a complete clearance of visual axis in the primary gaze and a good symmetry between both the eyes with no exposure keratitis. This is a patient who had multiple injuries, again, post-road traffic accident. So he had a telecanthus, he had a medial ectopion, he had epiphora, and he had a severe ptosis. So after multiple surgeries, this is the final picture of the patient who's happy, asymptomatic. Hence, we conclude that management of post-traumatic ptosis depends on the etiology, the time between the occurrence of the examination, the degree of ptosis, and the levator function. Potential for multiple trauma subtypes to occur from single injury means that a patient may not always fit into one discrete subtype, and we need to assess everything as a in toto. Surgical approach and timing varies with each case and is a challenge for the orthoplastic surgeon. Due to the inherent variability in the mechanism and severity, it is difficult to determine the final prognosis and the final result. And management is often on a case-by-case basis, and patients may need resurgery due to under or overcorrection. Thanks.
Thanks, Smriti. It was a very detailed description of all the modalities. And just to summarize, I think the most important aspect is that it has to be a very thought over plan of action, and one should not rush into repairing a traumatic ptosis, because there may be an aberrant regeneration also of nerves, and the ptosis may resolve because of that. And not only that, as you have rightly said, that it may be not only just the ptosis, the patient may have had injury to the other nerves as well, and as soon as you try and correct it, you may end up with an exposure keratitis due to the poor bills. So further, even if we are working on a levator resection or reinsertion, many a times because of excessive fibrosis, the results may not be the way we would expect in any other LPS resection. So these things need to be discussed with the patient in advance before we take up these patients for surgery. And thanks, Smriti. I think Dr. Raj has joined. He had some issues, wrong hall had been given to him. So we'll first finish all the talks and let's see how much time we're left with. So Dr. Raj, please share your screen now, and he will be talking about a very significant topic, and that is the rehabilitation, the prosthetic rehabilitation, which is a very challenging task in most of these patients. We have young patients involved in RTA, and to have a poor cosmetic outcome after the trauma, the whole thing, the patient has a long life to go ahead with. So over to Dr. Raj Anand, please. He's a senior consultant at I7 group of hospitals. Am I right, Dr. Raj?
Yes.
Okay. So Dr. Raj, please, you can share your screen now.
Can you see the screen now?
Not maybe you put on your slides, please.
Yeah, my slides are there.
No, I can't see your slides as yet.
Okay. Go to share and then document.
Are you on laptop?
No, I'm on my mobile. There's some problem with the laptop. It was, I've opened the window, is there, just trying to, currently my screen share is not working.
So should we
need
some time for working it out? I can take the next talk in the meanwhile. Do you need some?
Yeah, you can take the next talk. Meanwhile, I'll see about the sharing part.
Okay. So please, I think you're okay. Then what I'll do is, Dr. Malik was going to speak on the glaucoma part of it. So what we'll do is
Can we take the session without the video if it's possible?
We can give him time. He has very beautiful videos. If he can open it, it will be great.
Yes, doctor.
Wonderful videos. So
yes, it's open.
Yeah. So no, this is another talk. Okay. So we are still waiting for Dr. Raj to resolve that issue. So many of course this was primarily a plastic session, but then I just wanted to share a case who actually was referred to me as for traumatic ptosis. But what I really want to emphasize by discussing this patient is that one really needs to examine the patient in totality. And basically the patient was having a lot of photophobia, and because of the the phakia, the mydriasis, traumatic mydriasis, and the high pressures, that the patient was uncomfortable. And it was not actually the traumatic process that had to be dealt with, it was something else. So the patient had basically undergone had a road traffic accident, and following which he had undergone vitrectomy, lensectomy, and despite the medical therapy, he was not controlled, and the options were, of course, a trabeculectomy with MMC, and already the vision had dropped. Even with the phakic correction in place, the vision was just 660, and waiting any longer would have really damaged his the optic nerve further. So this is just what a refractory glaucoma is, and these are the different. I'll just go ahead with the presentation. So what I decided was, this was a 22-year-old male, and he had a secondary glaucoma. So this was the lensectomy and vitrectomy done. His pressures were still 35 millimeter of mercury, and you can see the cupping was nearly 0.8. And we know that trabeculectomy has 75% failure rate. So now I was in a dilemma. I decided to go for a glaucoma drainage device. This is the periotomy being done, and cauterization of the conjunctiva. This is the MS glaucoma well, the priming being done, and this is a supratemporal quadrant where the plate has been pushed back and the plate is fixed to the episcleral tissue. Partial thickness scleral flap is dissected and in the limbus. And since it was being combined with a scleral fixation, so this is the partial thickness scleral flap at 2 and 8 o'clock position for the scleral fixated IOL to be placed. So after this, a pre-placed suture was passed just to hold the tube in position. Mind you, this suture should not be very tight, otherwise it causes occlusion of the tube. And this is the tube being fashioned. A 2 to 3 millimeter of the tube has to go into the this tube was placed behind the iris, and this is a straight needle on 10O proline being passed, and this is a 26 gauge needle on the other side. The two are docked in the posterior chamber. And the proline, you can use 9O proline or 10O proline. Nowadays we use 9O proline. This is a entry wound. The sutures are brought out to the main wound, tied onto the eyelets, and the IOL is placed. This is a technique of burying the suture described by Dr. Malikoli. He has taught me this, and this gives a very good result. It does not allow the suture erosion or suture extrusion. It's a very good technique. So post in the 3 years follow-up after the surgery, the patient regained a 6/60 vision in the temporal field. As I told you, the patient already presented with a 0.8 cupping by the time he came to us. And there was what was nice was his binocular field of vision had improved and he was quite comfortable. His IOP was maintained between 10 to 14 millimeter of mercury till the last follow-up. After that, following pandemic, he was lost to follow-up. And the point is that again the story doesn't end here, because the success rate of approximately 50% was obtained at 5 years of follow-up even after an MS glaucoma valve. So one really needs to follow up these patients, and if there is a failure, you can actually go for a second AGV also. Although I have not implanted a second AGV in any of my cases, I usually supplement it with the topical drops and have been quite successful in getting a target IOP in most of my patients. Of course, the other option was a diode laser. A diode laser, micropulse laser is really picking up, and this is a therapy which has shown good results and up to 15 months of follow-up. the pressures are, what they you really want. Like in this patient, the initial attempt could have been made with a micropulse transscleral diode laser, and in most of these patients, we would require a long-term reduction because the angles may be totally destroyed. So glaucoma drainage devices, maybe whatever is good in anyone's hands, can be used. And the important thing is one should really needs to act fast, because the more delay you are going to do, the more irreversible loss of vision will be sustained. So I think all of us need to be comprehensive ophthalmologists and not just stick to one field sometimes, because you may pick up patients which may require multiple interventions, and you can give a very good this thing. Dr. Raj, are you ready now? Dr. Raj? Yeah, I think he has thought of devise some other way of doing it. Dr. Raj, please unmute yourself first. Unmute yourself.
Can you hear me now?
Yeah, I can hear you.
All right. And I think my screen is ready for share.
Yeah, great.
So now can you see my screen?
Yeah, this is very interesting, but yeah.
All right. Thank you, Dr. Ruchi. When it comes to rehabilitation, I think it is important to understand that what are the implications of losing the eye. It is more than just a medical complication. The impact is far-reaching on the social, personal, and the professional life of the patient. It's a tragic emotional event which has a very far-reaching implications. The person may always live in the constant fear of losing the other eye as well, and it affects all strata of the society. The magnitude of problem is huge. Looking at our population, even 3 to 5 per lakh is a huge number. And unfortunately, there is a lot of paucity of literature and lack of awareness about the options available to such patients. The goal of treatment is not just to give an artificial eye and get away. The whole idea is to help these patients lead a normal life without being discriminated from their because of their monocular status and abnormal appearance. Ideal rehabilitation program would include these 4 parts. First is train to use monocular vision to its full potential. I always refer this book to all my monocular patients. It's a beautiful book written by Frank Brady. He was a commercial pilot. When he lost one of his eyes in the accident, he not only learned to use monocular vision, he also made it possible in US for the one-eyed people to fly commercial planes. So that's the kind of recovery he has made after losing one eye. A very encouraging book for all my patients who are really depressed after losing their eyesight in one eye. Second is to deal with the psychological impact of losing one eyesight, and as I said, fear of losing the other. It's very critical that we protect the other eye, and all patients are strongly recommended to wear glasses which is shatterproof, that is either CR39 or polycarbonate, so that in case of any injury, those glasses protect the eye and patient can retain his vision. And of course, last and the most important is to restore the natural look, because without this, whatever you say and do, it doesn't carry much weight. So a restoration of natural look and ocular prosthesis. Before Second World War, it used to be mostly glass artificial eyes. After Second World War, PMMA was used to make ocular prosthesis in most of the labs. The basic difference between a custom-made artificial eye or ocular prosthesis and a ready-made eye, as you can see in this diagram, that the custom-made artificial eye sits snugly on the front surface of the socket without leaving any gap. Unfortunately, in case of stock eye, there is a gap between the back surface of the prosthesis and the front surface of the socket. This gap accumulates tear, which in turn gets infected and forms discharge, and patient always has to clean it regularly, and he or she is never comfortable. The tear dynamics with custom ocular prosthesis, which is fitted well, is such that tears flow in front of the prosthesis, and with every blink, it keeps cleaning itself. Therefore, we do not need to remove the prosthesis, and patient can continue wearing it for even months together without removing. The characteristics of ideal prosthesis, as we would all expect, that it should be comfortable to wear, it should be able to be worn continuously without frequent removal, there should be no discharge, looks of course should match to the other eye, it should maintain the lid position, contour and movement of the lid, and there should be no toxic effect, and of course there should be good motility of the prosthesis. What is more important in such cases that particularly dealing with young patients of microphthalmus and enophthalmus, the sooner we start, better it is. Why it is so? Because once we start giving prosthesis or conformer at early stage, it stimulates orbit development as well. If it is not done, then not only eye does not develop, along with the eye, there is no stimulus for the bony orbit to grow. And if bony orbit does not grow, you see that there is the entire, that half of the face does not grow. So a small thing like a small eye, microphthalmic eye, can lead to a facial hemiatrophy. This can be avoided if we start the treatment early and help bone to grow. In order to have a good prosthesis, there are certain prerequisites to be met. Only then prosthesis would be natural looking and comfortable. There should be adequate phonesis, both superior and inferior. Inferior phonics make sure that there is good retention, it does not fall off, whereas a deep superior phonics makes sure that lid movement is complete and there is no lag of thalamus when patient looks down or closes the eye. Optimal tear secretion is again critical. Patients who have had radiation exposure, they have dry sockets, and they cannot wear prosthesis comfortably. The volume augmentation is critical while we do enucleation or evisceration. Optimal implant must go in so as to replace the volume that is taken out, that is removed while removing the eyeball. Presence of orbital fat adds to the natural look. The orbital implant, if it is not well centered, can make the prosthesis retention or movement compromised. And of course, eye should be quiet. An inflamed socket keeps giving discharge. This is a small video to show how to meet those requisites. I hope I'll be able to play it. These basic things that we all are aware of, that while doing evisceration or enucleation, it starts from saving as much of conjunctiva as possible, because it's important to give them deep phonesis, both superior and inferior. There's some problem with the video. Yeah. So first we balloon the conjunctiva. This is important so that we can remove as much healthy conjunctiva and tenon as possible. Once we balloon it 360 degree, then we remove conjunctiva and tenon together. There are, although we suture it separately, but while removing, we can remove it together. So after ballooning, we are making a 360 degree cut all along and a few radial incision both on the 180 degree apart so that we can open it well. Tenon is separated from the underlying sclera. Once we mobilize this tenon, it is important that we should be able to bring it close while closing. So good mobilization is important. And then this corneal button is removed. While removing corneal button, it is important to remove all the epithelial tissue. If there is a remnant of epithelial tissue while removing corneal button, this can lead to retention cyst in future. So in the uveal tissue and the sclera. Once we reach that plane, usually it is possible to remove the entire content without any problem. And it is also important to remove the entire content so as to prevent future theoretical risk of sympathetic ophthalmia. This empty scleral pocket is meticulously cleaned with absolute alcohol. Absolute alcohol is supposed to denature whatever the choroidal tissue is there, and it prevents the potential risk of sympathetic ophthalmia. A radial incision, 4 radial incisions are given in the sclera for 2 purposes. One is to accommodate a bigger implant, and second to effect a good closure. We also make an opening in the posterior along the able to put optimal size of orbital implant. Therefore, opening posterior makes sure that we can put optimal size of orbital implant. Use of quadri make life very easy. Now the scleral shed is ready to remove the implant. Whatever bleeders are there has been taken care of. We held the 4 petals separately, put the orbital implant, and make sure that we are able to close the sclera without any tension. It is closed in 2 layers. First, the horizontal one, and on top of that, the vertical one. So it's kind of double protection against any exposure of orbital implant. 6-0 Vicryl is used to close the scleral flaps. It may be tempting to use a stronger suture like Prolene, but because Prolene does not dissolve, sometimes I have seen this Prolene that eventually leads to exposure. So it is preferable to use an absorbable suture and make sure that the scleral edges are well opposed without much tension. Even if we just pull together using force, sometimes it's likely to give way. So it is important that we mobilize the scleral flaps and it can be closed without tension. Now sclera has been closed in 2 layers, as I told. So, and then tenon and conjunctiva are closed in layer. It is important to close tenon very well because tenon is the only vascular tissue that brings the blood supply. It makes sure that there is no exposure in future. I think I'm running out of time. I'll skip the video.
Finish it up. You have so many, or the session is till 1:55. We have about
just a couple of slides.
Okay, please go on.
Okay, so if optimal care is not taken, we can land up with following problems, and that makes the optimal prosthesis fitting difficult. Patient may land up with contracted socket, or in case of absence of implant, there is significant volume loss that cannot be compensated. Or if there's a implant that has rough, sharp edges, that can cause implant extrusion. Or sometimes implants with rough surface can cause exposure of the orbital implant. So all these indications call for a surgical reconstruction to make sure that the socket has optimal findings. In case of radiation exposed socket, we need to give frequent lubrication. Motility of prosthesis comes from the motility of the socket, and how efficient the motility is from socket to the prosthesis depends on the area of contact. Presence and type of a central orbital implant gives a better motility. Healthy extraocular muscles ensures that there is adequate movement. And as I explained earlier, presence and depth of phonesis are critical for good movement of the eye. Transmission depends on contact between prosthesis and socket. A pegging device can help movement better. Weight of the prosthesis also affects movement. A lighter prosthesis moves better. And surgical technique like myoconjunctival technique ensures better movement of the phonesis and prosthesis. Prosthesis may be associated with certain complications, mainly like allergic because a foreign material is likely to attract deposits, and deposits in turn can cause a severe allergic reaction. To avoid this, prosthesis needs regular cleaning either with contact lens solution or once in a year polishing to make sure that the surface remains smooth. Ill-fitting prosthesis can actually cause chronic irritation, which in due course of time ends in a socket contraction. To conclude, as ophthalmologists, we play important role in the rehabilitation by providing optimal prerequisites for good outcome with prosthesis, forming a team with our ocularist, by ensuring the optimal vision in the remaining eye, and encouraging patient to lead a normal life. Thank you very much.
Thank you, Dr. Raj. I think we have just 2-3 minutes left now, and anybody wants to can you stop sharing,
Dr.
Raj, please? Can you stop your screen share? So basically, in totality, I think what we can conclude is that the initial management of trauma, can we have the panelist view now? The initial management of trauma is of the paramount importance, and what was suggested by Dr. Shalu, Dr. Raj, Smriti, that if the layers are sutured properly, if you do not know how to repair it, it is better to refer to some other surgeon who knows his job well, rather than to mess up things, and then it becomes even difficult to give any kind of rehabilitative procedure or prosthesis. So any panelist wants to add to whatever discussion, whatever presentations we had? Dr. Shalu, Smriti, Samreen?
You presented a case of aphakia with secondary glaucoma. I just like to add something that in patients with aphakia who present who had previous surgery like cataract extraction, they have vitreous in the anterior chamber. So vitrectomy should be done. Your patient was already vitrectomized. So vitrectomy should be done when we are putting the AGV. Otherwise, the vitreous plugs that tube and it fails the surgery. So we need to do the vitrectomy if we are doing the AGV in a phakic patient. If we
This was this is a very important thing. In fact, putting an AGV with SFIL itself was quite tricky, and thankfully it was already, the vitrectomy was done, because otherwise things would have become even more difficult for it looked simple, but it was not all that simple.
Because it collapses the globe, so it makes the surgery itself difficult. And doing combined procedure is very difficult.
In fact, just since you started the discussion, a small tip that if you have a situation of this kind, you want to do a vitrectomy and you can put a anterior chamber maintainer. So, that it maintains the turgidity of the globe, and you can do all the other maneuvers a little easy, not very easy, but a little more comfortably. So that is it. And I think we need to close the session because the time is over. Smriti, Samreen, you want to add anything?
Your video was very nice and very good night.
Thank you.
We would like to thank you for giving us this opportunity to speak on this platform. Thank you very much.
Our pleasure to have youngsters like you. So I think we'll close the session now. Thanks so much for being with us, and hopefully looking forward to seeing you next time physically in the next AIOS. Thank you so much.
Thank you, ma'am. Thank you so much.
Thank you so much, doctors, for the wonderful session.